The next talk is by Dr. Jatin Kothari. We all know he's very known faculty in our community, especially conducting APEX on regular basis. He's a director and chief at Nanavati Max Super Specialty Hospital, Mumbai. And over to you, sir, for your talk.
Thank you, Chairperson, and very good afternoon to all. This is going to be the outline of my talk. We'll start with a case so that people don't fall asleep. Pathology is obviously very interesting for all of us, and I will discuss a few points which are very important in this particular era of emerging therapies for C3G. The approach overall, some of the guidelines that have been outlined to give some standardization to the treatment of this difficult condition, and ending with some novel therapies and concluding remarks. So this is a patient who's came to our OPD about 3 months back with 6-month history of hypertension and was found to have some swelling on the feet. On evaluation, he was found to have a creatinine of 4.3. His urine protein creatinine ratio was 2.8. He had a few RBCs in the urine. Nothing else to write about. Kidney sizes were borderline, already seen by 3 nephrons outside, and then when he walked into my clinic, there were 3 more facing him. Eventually convinced him for a biopsy because there was one of the reports of the ultrasound which showed borderline kidneys, and he did not undergo a biopsy before he came to us. Eventually did consent for the biopsy, and this is what the image we've got. This is courtesy Anila Abraham from Renopath, who reports all our biopsies. This is the light microscopy H&E stain, which shows you the classical features of what we used to earlier call as membranoproliferative glomerulonephritis pattern. It was thought to be a disease initially, but now we all understand that it's only a pattern of injury. So the classical increase of the mesangial matrix, cellularity, and of course the basement membranes which are thickened, which will be seen in the further slides and the images. The pus stain clearly showing a beautiful crescent, not that good for the patient, but a fibrocellular crescent occupying almost 80% of the glomerulus, compressing the glomerulus on one side. This is the silver methenamine, which shows you the beautiful double contouring. You can actually see the deposits here, and it's widespread across the entire glomerulus, which is enlarged. On the immunofluorescence, C3 staining was very strong and the IgG stain was negative. And that's the reason why Anila gave us this report of membranoproliferative glomerulonephritis, which again, as I mentioned, is a pattern. It is not a specific disease. It was complement mediated, and the IF gave us the diagnosis of a complement mediated pathology. Garima Garg from Lal Path Lab gave us the images of the electron microscopy, where you again see these wonderful deposits all across, and this is what is described as the classical dense deposit disease, sausage-shaped deposits all across the glomerular basement membrane. Along with that, increase in the matrix and also mesangial deposits were also clearly seen on the EM images. So this was a diagnosis on EM, and again, you probably will not be able to give a specific diagnosis in a patient with C3G unless and until you have an EM. So my request would be that wherever it is possible, and now we have a lot of centers doing EM across India, we should be doing EMs to help us treat these patients better. So the features which were outlined is diffuse effacement of the foot processes. We saw the deposits which were all across the glomerular basement membrane, and this patient was obviously given a diagnosis of dense deposit disease. I have diverted from the topic of C3GN and probably covering more of C3G, and all of us know that C3G is further divided into C3GN and immunoglobulin mediated glomerulonephritis. This was a paper which Umesh Khanna put on his MKF group just 3 days back, which was a paper from the KDIGO Controversies Conference, highlighting the impact of complement on all diseases that we deal with on a day-to-day basis. As you can see on the left-hand side, the diseases which are outlined, atypical HUS, C3G, and primary immune complex MPGN, have a big role of complement to play. And as we go across from the left to the right, some other conditions where probably complement doesn't play that much of an important role, but is also considered as one of the factors in these multifactorial diseases. And all the other diseases fall somewhere in between, where probably complement still has a role, like we see in patients with lupus, etc. So I need to emphasize, and this is predominantly for the students, that MPGN is now only a histological lesion. It is not a specific disease entity. And once we see this pathology pattern, it is up to us to try and look at a possible diagnosis, rule out all the other secondary causes which should also show a similar pattern. We all know that thrombotic microangiopathy can look like this. Sometimes cryoglobulins can look like this. Even post-infectious can look like this. Obviously, we'll see more subepithelial deposits in post-infectious, but the kidney biopsy pattern should help us to look for possible causes and rule out secondary causes. Looking at the evidence-based approach for this condition, not much to write about compared to the other conditions which were discussed in the previous talks. The only recommended guidelines and indications for standard conservative treatment for all kidney disease patients is what we have in C3G. So RAS blockers, lipid lowering, and other renoprotective agents like SGLT2, etc. I don't want to bore you with this, you've already seen this, but this is just to highlight all the new drugs that are currently being evaluated for this condition of C3G. Factor B and factor D inhibitors, which would work on the alternative complement pathway. Some of the drugs downstream on the C5 inhibitor category, that's eculizumab, and all the other numbers, or other names which Sharad was able to pronounce, but I can't pronounce it. And C5a receptor antagonist, this is the only one actually which has helped us start treating these patients, and globally it is available. I don't think it is still available in India, but eptacopan. So this is the approach that we have to take as a clinician once we see the biopsy features of the MPGN pattern. As I mentioned, always look for the secondary causes, try and rule that out, because in those conditions you are going to treat the underlying disease with the supportive care that we already looked at. Once you see predominant primary C3G, where the C3 is dominant as is in our case, either it will be C3GN or dense deposit disease, or if you see IgG plus C3, then it's primary immunoglobulin mediated MPGN. In this, there is a role of looking at various complement abnormalities, and C3, C4 is something that we do as a routine, but probably down the line, we'll start doing most of these other factors, which will help us to find out whether the defect is upstream or downstream. And the treatment can differ based on these screening tests which are outlined here. Renoprotective agents are given to everybody, and if the patient has nephrotic syndrome, severe inflammation, and rapid deterioration, as in our case of rapidly progressive glomerulonephritis, there is definitely a role of steroids and MMF, and I will share the data with you as far as MMF goes. If there is no complete remission, you will have to consider one of the newer drugs once it becomes available. So starting with the conservative treatment, these are all the trials looking at various agents that we have outlined: ACE inhibitors, lipid lowering, sodium restriction in the diet, SGLT2, steroids. Important to note in steroids was the dose of steroids is about 1 to 2 milligram per kg per day. Yes, sometimes when patients present with nephrotic and rapidly progressive glomerulonephritis, as in our case, we can pulse them also. Mycophenolate, the dose is 600 milligram per meter square, so it's not the classic dose that we use in transplant, and you can get away with lower doses. The response, as we know in MPGN pattern kind of diseases, is much better in children and younger adults. The response is not as good in the adult population if you see this disease, like in our patient. Sometimes if you are able to measure the C3 nephritic factor, which itself is an auto-antibody proliferation, which leads to proliferation of the complement cascade, these patients actually do better if they are positive for the C3 nephritic factor. Only about 30 to 50% will respond, and most of the patients will relapse after you stop the treatment. So the duration of treatment is something that we don't have much information on. Compared to other conditions which were looked at in the previous few talks, CNIs and cyclophosphamide have not been useful in this condition. Unfortunately, rituximab, as we all know, works on the B cells, and this disease doesn't have much of a role for B cells. So rituximab also doesn't work in the primary C3G. Yes, it has a role in lupus nephritis and in even some conditions like myeloma, which also will show you the same histopathology of an MPGN pattern. Looking at all the MMF trials, these are historically all the case series and all the retrospective studies that have done with MMF. Most of the studies have shown no difference. There are a couple of trials where the survival in terms of kidney function and retardation of progression was better with MMF compared to other agents like azathioprine. So there is probably some role of MMF, and as I mentioned, if the patient is nephrotic, then probably giving them steroids and MMF is the way to go forward. Coming to eculizumab, a lot of promise 10 years back about all complement-mediated diseases being controlled by eculizumab. Unfortunately, in C3G, the promise of eculizumab has not stood the test of time. There are two big trials, obviously, which looked at eculizumab in the C3G population. One was a retrospective French study, which is in the first study, and there was an EAGLE study which looked at, which was again an Italian study, which was randomized to try and use eculizumab in this condition, but not with much promise. What they've recommended is that when you are using eculizumab, already the cost is very high for our patient population. You will need to monitor C5 to C9 levels, and again, that is not very easy for us. The predictors of response again is the patients who have more inflammation and who have more rapid progression are actually the ones who do better. One of the papers that I read from Giuseppe Remuzzi was mentioning that there is actually loss of eculizumab and MMF in the urine if patients have proteinuria. So those are the patients who will need to be monitored, and you will have to give a higher dose, and some of those patients who were given the higher dose responded very well. Probably the role of C3G combined with the atypical HUS is where probably eculizumab still stands a good chance of causing a remission. Coming to all the new drugs again, and to pronounce all these drugs is a big challenge, but the phase of the studies is what is important. What is there in the green are all the 3 trials which are phase 3, which are all ongoing, so we don't have much data from all of that. But the Avacopan, which I was mentioning, which is a C5a receptor antagonist, is the one which has shown a lot of promise and probably will stand the test of time and help us for patients like this. So coming back to the case, this patient was pulsed because of his rapid progression and severe proteinuria. He was advised full dose of MMF. Accidentally, I had not read the trial at that time, and the trial actually recommended half dose, which one of my previous colleagues had already started, which the patient was doing well. His creatinine did come down to 2.6 in about 3 months. Of course, he was on a dose of ARB, depending on his blood pressure. His albumin levels were improving, and he lost about 6 kilos while he was on the treatment. This is my concluding slide, where again, the same paper from Remuzzi mentions about an approach that we probably will need to take in the future. We will have to classify these patients and put them into clusters, depending on their histological features, depending on their clinical features, and some of these genetic testings which hopefully will be doing more and more. So cluster 1 and 2 is where predominantly the alternative pathway activation is happening, and until the terminal pathway it is very much activated, where anti-factor B and anti-factor D drugs will be helpful. There might be some role of C5 inhibitors also. Cluster 2 is where probably there is an overlap with the classical pathway activation also, where more broad inhibition of C3 is recommended in these class of patients. Cluster 4 is where we would probably be looking at specific inhibitors to the complement pathway downstream, especially drugs like iptacopan, which might help us to prevent the side effects of the other drugs which have more widespread complement inhibition, because of course the patients are going to be exposed to a high risk of infection, which we'll have to continue to monitor. Thank you for your kind attention, and I'm open to questions.
Thank you, sir, for completing in time. As the topic is very interesting, the small question from my side. Have you ever encountered C3GN and presenting with systemic features of TMA, having anemia, thrombocytopenia, and high LDH?
Yeah, so as I said, the overlap is something that is seen very, very clearly. The biopsy features will be pretty much similar, and unless and until you do EM, you may not be able to differentiate from the dense deposit disease that we would see. So yes, it has been seen, and there are a lot of published case series on this also. This is probably the area where your eculizumab will still score over all the newer drugs. But otherwise, it looks like the C3G is going to be taken over by the specific blockers of complement. I'm sure people in the audience have seen an overlap of TMA with the C3G also.
Any questions from audience?
Thanks for an excellent talk. My question is regarding patients who lose their kidneys due to C3GN. Would you transplant, and what strategies would you use in the current drugs that are available to us?
So C3G, unfortunately, there is still a lot of overlap between C3G and IG glomerulonephritis. There have been follow-up biopsies of patients which initially looked like C3G with predominant C3, and subsequently when biopsied, they showed more of IgG. So the differentiation that what we are talking about is still not crystal clear. Coming to the recurrence, overall, whether it is IG, MPGN or C3G, the overall recurrence rate is 50%. But still, if you are able to do the genetic testing, and probably the ones which have the genetic variants may do worse compared to somewhere where you are able to find out a cause. As a rule, I don't think we deny transplants to anybody who's got this condition, but the recurrence rates are much higher compared to IgA nephropathy and other conditions. I think Bharat must have covered about the recurrence and the treatment. Is Bharat around? Yeah, you must. Couldn't see the screen.
Any more questions?
Some patients who presented to us with end stage with C3G phenotype, and two of them had dense deposition disease. I think any C3G phenotype, we should look for any genetic mutations in them, and because these are diseases which will have a lot of overlap between MPGN histology and your TMA. Two most important what in the course we have seen is a DGK mutation. So DGK is one thing where you transplant these patients and they do extremely well even with C3G, and the complements continue to remain low, and their long-term outcomes are also excellent as compared to the C3 glomerulopathy, which is immune mediated. The other thing what we have seen is congenital complement deficiency with C2 complement. This is one we transplanted where the patient rapidly worsened with onset of MPGN pattern on histology with low C3, C4, and the histology showed dense deposition disease with a congenital complement, and we successfully did a transplant, and it's almost 3 years it has shown no recurrence.
So you mentioned about C2.
Yeah, congenital C2 yeah, so it's
actually, if you look at the complement pathway, C2 you would think
yes,
more of classical, but
so this is a presentation with classical complement pathway, and this patient also did extremely well. So the point is, whenever we are seeing patients with complement presentation or patients with MPGN pattern on histology, it's always better to see whether they have responded to immunosuppression or not. If the patients are responding to immunosuppression, then and there is a C3 specific deposition, then it's always better to look for nephritic factors before we are subjecting them for a transplant. And it's very important to know whether they have an antibody which is mediating the problem. And these patients, if they develop a recurrence, they become amenable to plasma exchange and rituximab. So that is one thing which we have learned over time.
Fair point.
Thank you, sir. Thank you, Jatin sir, for excellent coverage and finishing on time. We still have 1 minute left.